We're just going to let everybody get into the webinar here. This is Craig Kennedy with MHPA. Thank you for joining. Just going to give everybody a couple of seconds to get on. I can still see folks joining, so thank you very much. We'll get started in just a couple of seconds. Once we see the attendee level start to level off, we'll get rolling. Thank you everybody for joining today. We'll be with you in just a second. Thank you. I think we'll get our webinar started for today. Thank you everybody for joining us. I think the attendee list is leveled off as people joined right at 3:30. Thank you very much for being prompt. And we want to keep this webinar on time. Good afternoon, everyone, and thank you for joining us today for this congressional briefing. It is entitled Managing the End of the Public Health Emergency, Best Practices in Medicaid. I wanted to first thank our congressional sponsors, Congressman Marc Veasey and Gus Bilirakis. We're extremely thankful for their leadership and look forward to working with all of you on this extremely important issue within the Medicaid program. My name again is Craig Kennedy. I'm the president and CEO for the Medicaid Health Plans of America. Our members, we're a membership organization. We have members in 40 states across the country, DC, Puerto Rico, and today our members serve about 48 million covered lives within the Medicaid program today. We're very excited to have several of our members represented here for this conversation about the end of the public health emergency and what it means for Medicaid. But first, as we get started, I just want to go over a couple of session logistics for the webinar itself. This is in listen-only mode. If you have any questions throughout the webinar for the participants, if there are any questions that you have, just put them into the Q&A section by clicking the Q&A button at the bottom of your screen. We respectfully ask that questions come from congressional staff, as this is a congressional briefing, or members of Congress and their staff, whoever, that we would like to prioritize those questions for this briefing. Please avoid using the chat feature. I think it has been disabled, but that will not be where we will get the questions and answers from. We'll do it through the Q&A button. And our presenters will address all the questions at the end. So we're going to run through the presentations and then we'll get to the Q&A, but you can put in your questions and answers at any time. We'll also be sending out a link to this recording, to the recording of this session and a resource guide at the end of this, which we'll talk about in a bit. And so with that, I'll turn it over. I'll go through the panelists that we have with us today, the distinguished panel. First of all, we have Kathleen Wee, who's the Chief Executive Officer of United Healthcare Community Plan of Maryland. She'll be our first speaker. Our second speaker is Dr. Jason Dees, a board certified family physician and executive vice president and chief medical officer at Molina Healthcare. Then we'll have Kristen Metzger of Elevance Health. Kristen, see, I'm still getting Elevance Health. I got it though. Elevance Health, and she's the Medicaid president for the East region. Courtney Thompson, who is the market president of Select Health of South Carolina. And then our final speaker is Patty Barnett, who is the regional vice president of health policy at the Centene Corporation. Wonderful speakers doing the on-the-ground work, and you'll hear a wide variety of perspectives today, but really preparing for this historic Medicaid redetermination process. And you'll hear that term a lot, redetermination process, that corresponds with the end of the public health emergency. And we're here to engage with you on what that looks like, what your role is, what our role is, and how as congressional staff, we can support you and your constituents during this transition. So with that, I'll keep it on time as best I can. I'll turn it over to Kathleen Wee to get the panel started. Thank you very much.
Wonderful. Good afternoon, everyone. And thank you, Craig. Craig has asked me to start out today's conversation with just kind of an overview, right, of the challenge that's in front of us with Medicaid redeterminations. So first, my name is Kathleen Wee. I am the CEO of United Healthcare Community Plan of Maryland and the District of Columbia, serving members right here in the National Capital Region. United Healthcare Community and State, we serve over 8.5 million Medicaid and dually eligible members across 32 states and obviously here in the District of Columbia. The COVID pandemic has affected us all. Can everyone hear me all right? Okay, I'm getting a notice in my Zoom, so apologies. So the COVID pandemic has really affected us all personally, but COVID has had a disproportionate impact on vulnerable populations. As you all know, Congress passed the Families First Coronavirus Act to support individuals and the broader healthcare system through public health and economic disruption that was caused by the pandemic. Prior to the pandemic, Medicaid programs across the country typically would redetermine individuals' Medicaid eligibility once every 12 months, which kind of resulted in some people losing Medicaid coverage if they had a change in their income or in their life circumstance on a kind of rolling and consistent basis. Under the Families First Coronavirus Act, states receive additional federal matching funds, and in return, states must maintain individuals on the Medicaid program until the end of the public health emergency. So because of the congressional action and people getting onto Medicaid and then essentially not leaving Medicaid for the past since the pandemic began, Medicaid enrollment across the country has increased by 26% since February of 2020. On behalf of all of us, we really thank Congress for maintaining individuals' access to the Medicaid program during the pandemic. Consistent Medicaid coverage prevented coverage gaps and maintained access to care for members who were already experiencing tremendous disruption and barriers to their ability to stay healthy during the pandemic. So, as we look forward, states across the country are preparing to resume the normal Medicaid eligibility processes at the end of the public health emergency. CMS has provided guidance to states to prepare to initiate eligibility processes and to engage a wide range of stakeholders who work with and support beneficiaries. I think that you'll hear from my colleagues that states really, although there's a lot of variation across states, states really share some core challenges. As redeterminations begin, their states are going to have to process an unusually high volume of eligibility determinations. States will have to educate members that they will actually need to take some action to be able to redetermine their eligibility. And for some members, this will be the first time since early 2020 that they are engaging in that process. And then states also will have to provide assistance to members who lose their Medicaid coverage and need to find some alternative form of insurance coverage. States who have Medicaid managed care programs, and all of us on the phone, we're all participating in programs across the country. States with MCOs often will look to us as health plans to be a critical partner in conducting outreach and education to members about the actions that they need to take in order to initiate their Medicaid redetermination and to connect them to resources to complete their application process and then seek some other form of coverage if they find that they're not eligible for Medicaid any longer. United Healthcare Community and State and Medicaid MCOs across the industry, we are all incredibly committed to supporting our members and our state partners with the resumption of the Medicaid eligibility determination process. We all share the goal of helping our members to renew their Medicaid coverage if they are still eligible, or to find another form of insurance coverage if they are not eligible, to ensure that they do not experience a gap in their coverage. So that is the kind of overview of the redeterminations problem. The colleagues who will be following me to speak to you today, they will be sharing more with you regarding the role that MCOs play to support both our individual members and our state partners with the Medicaid redetermination process. So thank you all for your time today. And from here, I'm going to turn it over to Dr. Dees from Molina.
All right, Kathleen, thank you so much. Thanks for that overview of where we are and for setting the stage for us as we go about this conversation today. Thank you all for joining us. It's great to have you here. On behalf of Melina, thank you for all that you have done to help navigate the country as we've moved through the last couple of years and COVID and the effects on its society. I am a family physician by training and still practice as a hospitalist about a weekend a month, although at the time when COVID was at its peak, it was much more than that. And I've been asked to bring this issue from sort of the health policy world down to the bedside. And anytime I'm asked to do that, I like to do it with a story. And I'm going to share the story of Brian with you. A few weekends ago, I was called by the emergency room physician with a patient who was septic, which is a really bad infection, because he had an abscess in his stomach. He also had diabetic ketoacidosis. So he had diabetes that was not very well controlled. Now, the good news is I'm going to not focus on the clinical issue of this during this call, but on the reason of why I received this call to admit Brian. Now, I have to say, Brian is a commercially insured member who lost his coverage, not a Medicaid member at this point, because he would have been continuously enrolled. But Brian is a patient that paints a bigger picture that I'm concerned about as we go through redetermination. Brian actually was a low-wage worker. The factory that he worked in had a downsizing because of challenges in the economy, and he lost his insurance coverage. He couldn't afford COBRA. He didn't understand how to apply for a marketplace plan or navigate through to the Medicaid agency to see if he might qualify for Medicaid. You see, he had really low health literacy. And that's my concern as we go through these next several months when we begin the redetermination process as the PHE winds down, is that we're going to have a significant number of citizens who actually may not understand the redetermination process or how they go about that. Why did Brian wind up in the emergency room? He cut his insulin by 2/3. He was trying to make it last longer. He got the infection in his stomach because he was actually reusing his needles as many as 4 or 5 times. As we think about that story, let's think about the over 14 million people who have the potential to lose coverage as the PHE ends and what that could mean. And I think it's fair that I share a little bit about some of the things that we actually have accomplished. For people that know me, I'm known as the eternal optimist. And I think there was actually one good thing that came out of COVID, and that is that we actually dropped the uninsured rate in this country from about 12% in 2019 down to 8% in 2022. More importantly, during that time, we closed the coverage gap in Blacks and Hispanics significantly as well. So a bright spot out of that as we've gone through the trials of the last couple of years. But there are many things that concern me as we go through redetermination as a physician who still practices and as the CMO of a large, primarily Medicaid insurance plan. We know that people who have insurance coverage, be that commercial, marketplace, Medicaid, Medicare, have higher rates of screening for cancers and chronic diseases. And if we unfortunately do find a cancer, it tends to be found at a much earlier stage when there is likelihood of a chance of recovery from that cancer. And I am concerned that we will find diseases at much more advanced stages and cancer at much more advanced stages as people lose their coverage. It's hard to have a conversation about healthcare at this point in this country and not talk about the credible need that we're seeing for mental health services. If you have a need for mental health services, it's difficult to find care if you have commercial coverage, much less if you have Medicaid, and then imagine if you don't have coverage at all. And we know that people who are covered, no matter the coverage source, have fewer unmet behavioral health care needs, and they get appropriate treatment at a higher rate as long as they are covered. I mentioned about screening for chronic diseases. Let's also focus on caring for those chronic diseases. And we know that if people lose their coverage, particularly diabetics, when they lose their coverage, only receive about half of the recommended care for their illness. So they are less likely to get their eyes checked. They're less likely to have appropriate screenings for kidney disease, less likely to have their blood pressure managed. So again, a concern, particularly with the increase in the incidence of diabetes that we're seeing in America at this time. Now, I think we would all agree that it's impossible to have a conversation about Medicaid and not discuss pregnant women and children. And this is perhaps a group that I am most concerned about, because we know that up to 55% of women who are covered under Medicaid are likely to experience a gap in coverage in the next 6 months. Now, that's pre-public health emergency data, but imagine as people come off of Medicaid, what that number is going to be like. And just to put that in perspective, that's almost twice the rate you see for women who have private coverage at the time that they deliver. And this disparity can be even worse for women of color. And of particular concern, that's the group where we see much higher maternal mortality, both before, during, and after childbirth. And so a real concern as we move forward. Now, fortunately, infant mortality is a rare event, thank goodness. But when you look at infant mortality in those who have coverage versus those who do not, the risk of mortality is about 2 times higher in those without coverage. Considering that there are estimates that as many as 7 million children could become uninsured when the PHE ends, it's definitely something that we need to be focused on and make sure that we keep children covered to any extent possible. I want to sort of wind down my part of the remarks talking a little bit about the long-term costs that are associated with continuous coverage versus not being continuously covered. There's a great study that says that on average, people who are on Medicaid and remain continuously covered actually are about 36% less expensive than those whose coverage is interrupted at any point in the preceding 12 months. So as you can see, there are some real clinical concerns as we move forward, but we have to all agree to partner together to work to ensure access to care as we move forward. I'm really looking forward to the questions that you all may have as we continue this discussion, but I want to leave you with an ask. One of the biggest reasons that people who are covered by Medicare don't complete their redetermination process is they don't get the paperwork that they need to fill out to continue their coverage. So as you all go back to your districts, as you all are speaking with constituents, ask them to make sure they're continuously covered. Ask them to know when their coverage ends. No matter if it's commercial coverage, a marketplace plan, Medicaid, know their end date and fill out the necessary paperwork to remain continuously covered. And also partner with hospitals and provider groups and social organizations in your districts to make sure that there is yet another voice promoting coverage, no matter the source of that coverage as we move forward. Thank you for your time. I look forward to the conversation during the question and answer. And again, thank you for taking time out of your busy days to participate in this conversation with us. And I'm now going to turn it over to Kristen to continue the conversation. Kristen?
Great. Thank you, Dr. Dees. And I really appreciate just how real you made it for everyone, sharing the story of Brian, and then also just making it real throughout with the examples that you gave of what people are experiencing with this. I'm going to hit on a couple of your asks at the end too, because it's so important. This is why we're doing what we're doing every day with the examples that you gave. So I'm Kristen Metzger, president of our East Region Medicaid Health Plans with Elevance Health, previously Anthem Incorporated. We officially changed our holding company name to Elevance Health on June 28th, and our new name really captures our commitment to elevating the importance of whole health and advancing health beyond healthcare for our consumers, families, and communities. We currently serve over 10.8 million individuals in Medicaid today across 25 states and Puerto Rico. Medicaid managed care plans have partnered with states throughout this pandemic to assist with everything from accelerating funds to safety net providers to ensuring beneficiary access to COVID-19 testing, treatment, vaccines, and more. As the previous panelists have described, state Medicaid programs will be faced with an unprecedented task of redetermining the eligibility of nearly all Medicaid enrollees when the PHE ends. At Elevance Health, we are focused on supporting continuous healthcare coverage and minimizing coverage gaps as critical steps towards improving health outcomes and advancing health equity. Our managed care plans across all of our members here are collaborating with our states, providers, and community organizations to ensure beneficiaries can maintain coverage, or if they no longer are eligible for Medicaid, are informed of and can access available alternative coverage, such as through qualified health plans, employer-sponsored coverage, and such. So let me talk to you a little bit about the role of managed care plans in this. And I'll start with three main focuses: partnering with our states, outreach and engagement efforts, and promoting smooth coverage transitions. Partnering with our states. Medicaid managed care plans' most important role is ensuring equitable access to healthcare coverage, whatever that appropriate coverage type is. And this includes making sure no one falls through the cracks during Medicaid redeterminations. This really hits on some of the examples that Dr. Dees was just giving. Fundamental to ensuring continued access to coverage is being able to actually reach people where they are and in the best way for them to be reached. If you think about where individuals are at, most of those who are in Medicaid right now have gone more than 2 years without an eligibility renewal, as Kathleen hit on. Many may have moved during this time, perhaps even multiple times during this period. That means our states may not have the most current address information on record for these individuals. One of our states is actually tracking returned mail, which indicates a bad address. That state has received return mail for close to 25% of our Medicaid members across the state, which means they are unable to contact that quarter of individuals who are using because they have a bad address on file. That's pretty astounding. Also, we have a lot of individuals who have never gone through any type of redetermination before and simply don't even know to look for it or what to expect. So I appreciate the asks of Dr. Dees again to remind people of that, to remind them to go look for it and to remind them to apply for it. So one of our top priorities in working with our states is to get updated address and contact information for our individuals and to influence our states to allow us to actually submit the updated information back to the states on behalf of the members. We're doing this through all types of member touches across our organizations, from case managers and community health workers and social workers that we employ who have personal relationships and connections with members, as well as through our providers, our pharmacies, dentists, transportation providers, and certainly through our call centers where members call into us. We're often able to obtain and maintain the most accurate and up-to-date contact information. But we really need the states to allow us to do something with that information. Many states are taking up some new program flexibilities that are provided by CMS to utilize that health plan member contact information, meaning the information, the updated address information that we obtain as managed care plans. We continue to encourage our state partners to adopt these various federal and CMS flexibilities, and thankfully, many of them are. For example, within our Elevance Health footprint, roughly half of our states are allowing us to collect and provide updated contact information back to the state for individuals. Additionally, we're asking states to examine and adopt all the other federal flexibilities that help really streamline this redetermination process and maximize the number of people who can maintain either Medicaid coverage if eligible or obtain access to other coverage. We've definitely seen a wide range so far of states who on one end are adopting many or most of these federal flexibilities and really want our health plans heavily involved, as well as to other states who have not wanted to even discuss with the health plans what their actions are going to be, what flexibilities they are going to want to take up, and how the plans can really get engaged. So wide variation, and of course, varying levels of state involvement in between. So targeted outreach and engagement efforts. Elevance Health is working to ensure a comprehensive strategy set in place to retain members and support coverage transitions. We are working in coordination with community and faith-based organizations and resources like navigators and assisters to ensure members are informed of the Medicaid renewal process and of those other coverage options, as well as how to even apply for those other coverage options if they are no longer eligible. To give you some sense of what we're doing across our Elevance states, is we're averaging roughly 300 different organizations within each state who are already planning events with us for the redetermination period post the PHE. Our elements of strategy include the following, and this is consistent across our most managed care organizations. We're developing communications and materials and tools from digital to electronic outreach, different ways to engage members at every level. We've got targeted engagement strategies for populations, some of whom Dr. Dees hit on, such as the pregnant women, women in postpartum time period, members who are aging out of their coverage, members who need communication in different languages, such as Spanish or Braille or large print. We're providing personalized videos that features closed caption options for members with hearing impairments. Many different ways that we're working to outreach and to really meet members where they're at. And then in 5 of our states, the states are actually taking advantage of another federal flexibility that allows us to provide, as MCOs, facilitated assistance with the renewal process, which is definitely a best practice that we are advocating for across our different states. The outreach and communications options with health plans that are able to use really vary by state and contract. And so we have been encouraging our states to provide the health plans with the maximum flexibility allowed under CMS. And then that focus on promoting the smooth coverage transitions is critically important. Health plans can play a very critical role in educating members about the other coverage options if they're no longer eligible for Medicaid, and helping make this coverage transitions more seamless. Within Elevance Health, we're well positioned to do this as we offer a broad suite of products across numerous states. We continue to work with federal and state partners to ensure individuals who are losing Medicaid coverage are both aware of other coverage options, as well as such as qualified health plans and employer-sponsored plans. And again, that states allow us for some additional data sharing. In this case, we're asking that states allow us to share lists of members who are no longer Medicaid eligible with other product options where we can do some very targeted cross-selling. This is another flexibility coming from our federal partners. And the additional ask there is, and flexibility being offered to states, is to allow for this outreach for up to 90 days post-disenrollment for the members. This will help us to really try to minimize the gaps in coverage for individuals. No doubt our states are going through so many challenges and opportunities with this. It's going to take a lot of very thoughtful and advanced planning on the state's part. We are encouraging all of our states to prepare a detailed state strategy and ensuring that it's in place in advance of the PHE. To do this in conjunction with the Medicaid managed care plans, as well as other stakeholders such as providers and community partners, and then to really leverage those federal flexibilities. There are many steps that states have to take in advance of the PHE end date, such as ensuring their IT systems have the capacity to manage these processes in large volumes that they will be processing of applications. They have to ensure they have the right staffing and training in place despite the workforce challenges many are facing today. And coordinating eligibility with navigators and assisters. They have to submit state plan amendments or waiver requests to the federal government for these various flexibilities that they want to enact. Another critical component that we're advocating for is to encourage our states to provide health plans with detailed lists of members who are coming up for those renewal dates, and giving that to us as far in advance as possible, which will allow us an even greater chance of outreaching to these folks to let them know what their options are, when their dates are, and the actions we need them to take. Certainly, we're encouraging our states to adopt other CMS flexibilities, such as taking the full 14 months to complete redeterminations, thoughtfully distributing the workload across those months as much as possible, and streamlining the Medicaid eligibility renewal process, including the use of passive renewals, using other program eligibility data, such as SNAP data, to renew members automatically. And then last, really focusing on that tracking and monitoring and making sure it's transparent and we have the right stakeholders involved to make sure that people are not falling out of coverage where we could have avoidable gaps in coverage. Health plans are very agile state partners and can pivot to help address barriers as they arise. And on behalf of all of us, we look forward to continuing our close relationship and partnerships with our states and at the federal level as we pursue this effort. Courtney, I'd like to turn it over to you.
Thank you, Kristen, and thank you to my fellow colleagues and everyone who's attending this webinar. Good afternoon. My name is Courtney Thompson. I'm the market president for First Choice by Select Health, a South Carolina Medicaid managed care organization that is part of the AmeriHealth Caritas family of companies. We serve over 420,000 lives here in South Carolina and over 5 million lives in 12 states and the District of Columbia. Thank you for this tremendous opportunity to speak on a topic that we at AmeriHealth Caritas are quite passionate about. Our vision speaks to empowering those in need, especially the underserved and disabled, and assisting our members during the redetermination process is just one example of how we live out this vision. Understanding the unprecedented nature of the pandemic's impact on Medicaid enrollment, a collaborative and comprehensive approach to the resumption of Medicaid redetermination should definitely be considered, and I know you've heard this from my fellow panelists. Medicaid redetermination has been paused for over 2 years, and as Kristen noted, many beneficiaries have never had to reapply for Medicaid. This will be the first time they've seen an application. Others have moved, others have new contact information. Despite these conditions, Medicaid managed care organizations have continued to interact with our beneficiaries. During the pandemic, we know what they've needed. We've continued to help them, and this positions us to complement the state's Medicaid agencies with their redetermination efforts. In South Carolina in particular, I'm going to talk about our real world experience. As Kristen noted, we've got some states that have had a lot of flexibilities in place and have done a really great job in partnering with managed care organizations. In South Carolina, the Department of Health and Human Services has engaged managed care organizations well prior to the pandemic to assist with these efforts. From proactive outreach campaigns aimed at obtaining updated contact information to working with our state partners to develop and distribute educational materials that explain the process, how to apply if you have questions in completing the application, to engaging community partners, provider partners to assist with the process, to ensuring cultural competency and health equity that are reflected throughout all redetermination efforts and materials. At Select Health and with the Department of Health and Human Services, we've been able to augment and enhance the core redetermination process to assist the state and our beneficiaries. South Carolina has taken that collaborative effort a step further. They ensure that all MCOs receive that precise list of assigned members that are at risk for disenrollment each month. And Kristen talked about that. So well in advance of a member's actual disenrollment date, the MCO receives that file, and the plans are encouraged to reach out to these families to ensure that they received applications, they received notices, they understand the importance of completing these applications and taking action. The plans are permitted to help provide replacement applications, assist beneficiaries in completing and returning the applications to the Medicaid office. They're allowed to provide approved redetermination messaging via texting and phone calls and emails and mailings. The health plans are even able to reach out to beneficiaries on that file after they're disenrolled for a defined period of time to encourage those members to take action to regain eligibility if applicable, and that helps reduce coverage gaps. After years and years of partnership with our state agency, we can confirm that these guidelines are beneficial and they reduce unnecessary churns in enrollment and gaps in coverage due to some of these administrative challenges that are associated with the process. In closing, based on our experience in South Carolina, we consider many of these interventions and practices to be the gold standard in MCO and Medicaid agency partnership, especially as it relates to redetermination. Specifically, managed care organizations should be provided the lists of individuals that are at risk for disenrollment well in advance of the date. Feedback loops that describe whether members have responded to applications and notices, have been deemed eligible or ineligible during the process. All of that information is incredibly valuable. As you've heard, managed care organizations have the ability to text and email and call, meet face-to-face, reach out in the community to their assigned beneficiaries to explain the importance of taking action. We can engage providers. We can assist with culturally and linguistically appropriate resources. Because of all of these capabilities at our fingertips, it is best practice to fully leverage managed care organizations for outreach. Outreach after disenrollment is also a valuable step. We want to minimize lengthy gaps in coverage that can impact health outcomes and access to care. Managed care organizations are valuable sources of updated contact information. As you heard me mention, despite the challenges during the pandemic, we've continued to reach out to our members. We interact with them frequently in the community and over the phone and via text. So we should be able to send this information to the Medicaid agencies as a source of truth. Lastly, we can't emphasize enough the value of transparency and strong communication between the managed care organizations and the Medicaid agencies. Particularly as we approach the end of the PHE, states are finalizing the redetermination strategies. Leveraging the managed care organizations for best practices and providing that level of transparency is really important. I again thank you and my colleagues for the opportunity to participate in this discussion, and I look forward to any questions you may have. And now, Patty, I will turn it over to you.
Thank you, Courtney. I'm so happy to be here with you. I'd like to thank MHPA, members of Congress, congressional staff, and all my panelists. My name is Patty Barnett. I'm Regional Vice President for Health Policy at Centene Corporation. We're an advisor of business on major state and federal policy changes and develop policy solutions and analysis to support our advocacy efforts. As I begin my closing remarks, I just wanted to note how I come to this issue and how important this issue is for Centene as we serve Medicaid, Marketplace, and Medicare members across the country. And as you've heard passionately from from our panelists about how committed MCOs are to supporting states in all of this. Prior to joining Centene, I spent about a decade at the Office of Management and Budget, where I was engaged in developing and implementing the Affordable Care Act's transformative eligibility changes. I understand just how complicated the state eligibility rules are and all the state options they have and the role they play in eligibility determinations, as well as the layered complexity of state-based versus federal marketplaces. The state nuances and the options compound to lead us to where we are today. I think I can all say confidently that we all strive to have a single door to coverage as envisioned by the Affordable Care Act. And we believe that the PHE unwinding presents an opportunity to finally get there and solve the systemic eligibility and enrollment issues in the long term. As we've learned today from Dr. Deese and other panelists about just how vital continuous coverage, uninterrupted care is during the pandemic, and how important it is for everyone covered under the Medicaid program. When the redeterminations occur, you've heard that just millions of Americans are at risk of losing coverage due to outdated and complex policies and procedures. I think we're also mindful of the state fiscal pressures necessary to maintain Medicaid enrollment increases, and we're closely working with our state partners, as you've heard today, on their timelines and their procedures. And I would say we are very happy to see that many states that we operate in are looking to take the full 12 plus months to complete redeterminations. I think we ultimately all want to get to a place where this is easier, where individuals can seamlessly transition between different types of coverage, different programs. If they're eligible for Medicaid, they should maintain their eligibility in Medicaid. If their circumstances have changed, they're earning more income, yet don't have an affordable employer offer, they should have awareness and the option to enroll in the Marketplace. As you've heard from Courtney and from Kristen, and from many others out here, many of our panelists, there are many effective state strategies. We are really excited about where the states have been headed in addressing some of the challenges. And while many are taking positive steps, we still see some procedural and opportunities for improvement and some opportunities to address some of the renewal barriers that we've seen over time. that could lead to improper terminations. So some of the things you've heard from the panelists: lengthy and complex renewal forms, direct mail challenges, direct mail issues, the lack of updated contact information, limited use of ex parte renewals, and healthcare literacy. We all know how complicated this is. Even for people that have been in the industry for so long, you've been able to enroll our family members into coverage. Limited time for enrollee response. We also see challenges within our contracts and regulatory barriers that prevent MCOs from educating and assisting members in redeterminations. We're happy to see that many states are taking advantage of the CMS guidance to address that. And I believe Kristen mentioned that opportunity to continue to work with members after disenrollment. All of this is made more complicated by staffing challenges and the huge burden that states are going to have to undertake to go through these renewals. And that's where I think MCOs can come in. I really wanted to kind of end with the potential role that we can play, as emphasized by everyone today, and just to highlight the solutions outlined by CMS. We applaud CMS for their leadership in outlining guidance to states, and offering a risk mitigating approach and state strategies, including some of the things you've heard today. So taking advantage of that full 12-month plus timeline, so plus the time to a couple months before to allow members to understand what's the process before them. Making the ex parte improvements to automate the process. Coordinating renewals with SNAP recertifications. Aligning renewals by household. Ensuring that we're no longer eligible for Medicaid beneficiaries are electronically transferred to their state or federal marketplace, among many other flexibilities outlined by CMS. And as you've heard, we can offer assistance, MCOs can offer assistance to really help fill the gaps where states are facing those staffing challenges. All that to say is we're here to help. MHPA and local MCOs can serve as valuable partners to ensure individuals maintain coverage or transition to the most appropriate forms of coverage. As we face the beginning of redeterminations and the unwinding, we just want to note that we're here to support you and your offices, which you will ultimately receive many questions and concerns from constituents. So we're here to support your needs, and MHPA can be a partner in all of this. With that, I want to turn it back to Craig. Really thank you for your time and really excited to hear your questions. Thank you so much.
All right. Thank you, Patty, and to the entire panel. Let me just make sure I have the right screen up here, as I got the right folks up, sorry, doing my webinar logistics as well. And I really appreciate all the comments from all the panels. And I see we have some questions and answers rolling in, but I just have a couple questions I want to ask real quick of the panelists before we get to the questions. But for everybody on the webinar, please use the Q&A button to ask questions of the panelists. We're going to jump right into those in a second. I just want to reconfirm, and now I seem to have lost her, but Kathleen, I was going to ask, well, actually, I'll open it back up. Kristen and Patty, you both mentioned the timeline. I just want to make sure that congressional staff understand the timeline around what these redeterminations look like. Both of you talked about the 12 months of redetermination that CMS has granted, but that starts when, that looks like when, how long is this going to go? When can congressional staff think, oh, this is going to be starting, this is going to be, when does the 12 months start? When does the 12 months end? What does it look like from here to there? Maybe I'll start with Patty. Sorry, Patty, if you could just give a timeline of what that 12 months looks like.
Sure. So I think this all starts with the HHS guidance, which said that they would give 60-day notice to states before they would lift the public health emergency. So all of this, that is really going to be the catalyst in which this all starts. CMS has provided different options for states, but And we can get into a little bit more detail and offer additional information, but that 60 days that they can start to contact members and beneficiaries and to kind of educate them on the process. And then CMS has given states 12 months to complete that process. And there's different ways in which they can do that. And I think that's where states are really starting to put together their plans. But that's kind of in a nutshell, just kind of how the clock will get started. But yeah, Kristen, please jump in with any other detail.
And Kristen,
Yep.
if you could talk about how different states are addressing those 12 months, Kristen, right? You spoke about the wide variety of states. They have this 12 months. What are you seeing in the different states? Are they taking all 12?
Yeah, a lot of states are now taking all 12 and are committing to that. Some are quite frankly concerned of how they even get it done in those 12 months, just due to the large volumes and putting it through their systems and the staffing needed to address it all. But there are some states who are still looking at trying to do it in a shorter time period. Some have said 6 months, for example. But we are seeing states continue to change as it's becoming a closer reality, as we think we're getting closer towards the end of the lifting of the PHE. But yeah, it varies. But I would say most of our states are now at a 12-month time period that they're looking for.
Courtney, South Carolina, have they given you a timeline?
Yes, so they are looking for 12 months as well. And I think, to reiterate Kristen's point, given the volume, a lot of states, I hope, will consider the 12 months as well. It's just the magnitude of individuals that are going to need to go through this process. I think it would be incredibly challenging to do it on a compressed timeline.
Okay. And Dr. Dees, actually 2 quick questions before I get too far. Dr. Dees, given that timeline, and Medicaid populations, needs, and health status, are there specific diseases within the populations that you see over a 12-month period that eligibility is important or more important? I know we have a large number of diabetics. I know we have a large number of different types of populations. You mentioned a couple, but if you have 12 months of eligibility and you have states doing different things, what kind of vulnerabilities within the diagnosis space do you see as really affecting Medicaid over 12 months?
Craig, great question. And I think there are a couple of things that come to mind. Those women who have high-risk pregnancies, particularly if they have a pregnancy that's going to go beyond and say a state that's going to push everybody through a 6-month period, and they are early in that pregnancy and they know it's a high risk that they could lose their coverage. That's a real big concern for those pregnant moms. And then the other group that comes to mind are those people who happen to be on a transplant list and where they might be extremely high risk in making sure that we land them on some sort of alternative coverage. But those are the 2 big ones that come to mind, or those with some cancer diagnosis that are in an active course of treatment as well. So I think those are the 3 big ones that come to mind, Craig.
Yeah, thank you. Got a couple more questions about the end date of the public health emergency right now. Just to let you know, right now it was extended in the middle of July through middle of October about, right? It's 90 days from there. As I think Patty mentioned, they'll give 60 days notice if they're not going to renew. But right now, the public health emergency goes into October, and then that you've already had 60 days notice. So October, right now, if nothing changes, is the end of the public health emergency and the beginning of this 12-month clock. So that answers actually a handful of our questions on this. Let me read one of these. Can you share if states you work with are all ready to begin this sounds like a Kristen question. Can you share if states you work with are all ready to begin the redetermination process? Additionally, can you share how you plan to work with states that choose to take fewer than 12 months? You mentioned that most are taking the 12, but how ready do you say states are? And for that 12 months that aren't taking it, how's that interaction going?
Yeah, I'd say Many of our states are very ready for this, as shared. We already have quite a few who are allowing for the managed care plans to partner with them. They're taking advantage of federal flexibilities. You heard about South Carolina from Courtney and how ready they are. So many of our states are very ready to start this. There are still some concerns, as you heard from Patty, on the workforce and just hiring people to get them ready. Some states still have some system, I'll say, enhancements that they're trying to work through to get themselves ready for it. But most are ready. There are some states who have not shared their plans with us yet, and I would encourage any members of Congress to go back and talk with your states about what their plans are to understand it. And if they have not shared their detailed plan publicly yet, they're not involving key stakeholders, to ask them to get involved and to make sure they are sharing that plan out. From a standpoint of those states that are choosing to take fewer than 12 months for redeterminations, we will always be good partners for our states and work within the parameters of what they're giving us. And so in those situations, if they're not able to take the full 12 months, we're strongly encouraging that data sharing that Patty talked about, of giving us, and Courtney hit on this too, giving us advance notice of which members are going to go through that redetermination process and when, and allowing us to help in the process, bringing us through to be strong partners for them.
I'm going to come back to you on another question that's coming up, but I'm going to jump to Dr. Dees really quick. And this is probably a bigger question. What will happen with testing and vaccination infrastructure when people are uninsured after the redetermination process and churn happens? Now, reminder, vaccination and testing is in a different structure of payment and stuff like that, but how does that again impact uninsured individuals if you lose redetermination? What does that mean within the vaccination, the grander testing, if you're uninsured? How does it impact those folks?
Yeah, great question. Lots of issues around that particular one. Obviously, they would have to be able to pay for that, the administration of the vaccine, but you've also got to deal with how widely available our vaccines going to be, because those that might be still under an emergency use authorization, although we do have fully approved vaccines now, but they would have to become parts of formularies and be widely distributed. Obviously, they would have to be made part of, for the Medicaid beneficiaries, for part of the Vaccines for Children program for those that are covered under that program. So it would pose some new challenges. Testing could become an issue if you can't get over-the-counter testing, and then how would you pay for testing in a provider's office, as well as potential out-of-pocket expense. So it would open up a whole new set of items, much like we have today for people that are uncovered and having to pay for care out of their pocket that they might not have access to once they lose Medicaid eligibility.
I see the Congressman is joining real quickly. I was going to ask another quick question of Patty, but I will also happy to turn it over to our sponsor and our host, Congressman Veasey. Unless you want me to pose another question, we have a string of questions. A great group of panelists here just walk through a whole lot of challenges that are facing states in the redetermination process. But obviously, happy to turn it over to the Congressman whenever you would like.
Yeah, no, absolutely. Yeah, y'all do have a great panel here talking about something that's hugely important to my state, and that is obviously Medicaid. And as a member of the Energy and Commerce Committee in particular, this is an issue that we talk about and discuss quite often. And so I'm glad that y'all are here talking about Medicaid health plans of America today, because it's really something that we need to talk more about. I mean, when you think about, for over 60 years now, Medicaid has really been a great tool and provided coverage for so many vulnerable communities. The district that I represent in Dallas-Fort Worth, I have the highest percentage of uninsured out of any district in the entire country. I have about a third of the constituents that I represent that don't have their own healthcare insurance. And so you can imagine just how difficult that is. And if there's one thing that goes wrong in the entire healthcare system. The people in the district that I represent usually bear the brunt of that the most out of the million plus in DFW Metroplex that don't have healthcare insurance. And we really got to see a lot of that during the pandemic, obviously, during the height of the pandemic. We're still in the pandemic, but during the height of the pandemic, we obviously got to see a lot of that. We almost had one of our federally funded healthcare centers close. And so it just really brings into light really just how important all of this is. Excuse me. So it just really brings into light just how important Medicaid is, and that's why I'm happy that y'all are having this discussion. I think that we need as many people talking around this issue as much as we possibly can, sitting around the table, having these discussions, just because, I mean, it is, as I went over the numbers in my district for district that I represent, I mean, this really is a life or death situation for many of the constituents that are represented. And if we don't figure out Medicaid solutions for many of them, you're going to continue to see these healthcare disparities rise. And I talked about the pandemic. I talked about the fact that I have so many in my district that don't have insurance in the first place. I talked about the million plus in DFW that don't have insurance. And I talked about how almost lost the federally funded healthcare plan. But at the same time, we have all these people that are moving to Dallas-Fort Worth too, and that's putting a lot of upward pressures on things like rent. The rent here in the Dallas-Fort Worth Metroplex used to be fairly reasonable, but it's gone up significantly now. Again, you can imagine in that type of environment, the role that Medicaid plays. I mean, it is literally the difference in whether or not just people get health care, but whether or not they're going to have discretionary income to have other things like be able to buy food or make the rent. It is really that crucial. So again, I just appreciate each and every one of you being here today, again, as a member of the subcommittee. I look forward to having these discussions, talking with you more, working with you more, because it is something that is for many of our districts around the country, we're in desperate situations, but for really all 50 states and in most areas in the country, this is obviously something that's been very, very beneficial.
Thank you, Congressman. I'm trying to learn how to unpin these things, so sorry as I move our view back. Thank you very much, Congressman. I can see every single one of the panelists as you spoke about the social determinants of health, housing, transportation, rent, all these different things, food. They were all like, I could do a whole nother webinar just on that topic. So we're looking forward to the next one with you to go even further into how MCOs can help on that topic. I can see all of them are like jumping up and down to go into those topics, because that's exactly what we're looking to do, right? That's exactly what Medicaid managed care and Medicaid as a national program is intended to help with, is folks' lives and productivity and engagement strategies. And so I know we're getting very close on time. I'm going to ask one more quick question, and I'm going to do it in twofold. Patty Barnett, you mentioned ex parte renewals, and then Kristen, you also mentioned how states were kind of rolling out renewals and different categories of people and how they're kind of doing it. I just want to make sure folks understand what that means, that there are different types of categories of people and that states have plans to address these. We had a lot of questions from folks that said, what can congressional offices do to help? Which I think is, I'm trying to phrase Kristen's question and ask your state for the plan. But Patty, ex parte renewals, real quick, what is it?
Sure. So think of it as Medicaid. Traditionally, you had to fill out long paper applications. Ex parte is the opposite of that. It is behind the scenes checking what available data is available to the state to determine your eligibility without the beneficiary having to go through a lot of hoops. And that is really what the expectation is of states, and that we're hoping to see more states continue to leverage ex parte as opposed to rely on the more traditional application type base.
And Kristen, you had said the question about what can congressional offices do? You mentioned getting plans from states. Can you just elaborate on that a little bit more?
Sure, I think it's, yeah, sure. I think it's worth talking to the states and administration about what their plans really are, making sure that there is transparency in their plans. They've got advanced communication, that they have a plan for how they do take advantage of hopefully the full 12 months, that they are taking advantage of things like the ex parte and SNAP and other forms of information that can help auto renewal people and really reduce those who have to go through this process. And that they're really taking advantage of all those federal flexibilities that are being allotted to them, and partnering with their managed care plans and providers and such on those plans. So I just encourage that you get to that local level. It's going to take definitely partnering with the administrations on it to understand what they're doing.
I know we have a whole nother webinar to go through, which we could, with all the questions that had come up. So thank you, everybody. We are at, I'm 1 minute over, and it makes me crazy when people go over a webinar. So I apologize for that. So I just want to wrap up real quick and say thank you to everybody that joined for this. We will be sending out a link to all the registrants and attendees about the video that we have recorded this. So it'll be on our YouTube channel. MHPA has put together a redetermination one-pager. It's actually more than one page, I think, but there's a lot of information to go over, as you've heard, and we'll send that out as well. I'd just like to thank Congressman Veasey for joining, Congressman Bilirakis for sponsoring this, and all of the leadership of our membership and everybody on this panel for taking the time today to go through this extremely important issue, which is Medicaid redeterminations at the end of the public health emergency. So I hope everybody found that the presentation's valuable. We have a lot more information to share at any time. Happy to answer questions. I'm going to share my screen, which is our contact information for Sean Garrity in particular. You'll see this is the end of it, but Sean Garrity is our Director of Federal Affairs, and he helped put all of this together, kind of led our efforts in that at MHPA. So you can reach right out to Sean with the email address here. You can also find him on our website, and he's also the one that emailed you about the briefing. Thank you very much to the entire panelists. I literally get very excited to sit here and talk with you all for a lot longer, but we promised an hour, and so we will stick to that. Thank you all very much, and thank you to all of the congressional staff that joined us today.